Hi, everyone. Welcome to Empowered with Gina podcast. So, I'm always talking about education. One of the other topics I love talking about is our health and wellness. And today I have a super powerful, brilliant, educated, gorgeous doctor with me who is now my new friend, Doctor.Celebrate.
Thank you for that introduction. That's so nice of you.
You're welcome, my friend. Welcome. Welcome to the podcast. Okay, so I always ask my guests, first thing, 3 adjectives that describe you.
Yes. Okay, so first one I think is multifaceted.
Okay.
Second is celebratory. And third is empathic.
Okay, empathic.
Yeah.
Oh, that's a
Very
good one.
empathetic,
None of
yeah.
my guests have ever said that one.
Yeah.
Good.
I feel like
Well, you are a
on.
doctor, so
Yeah.
that's a good trait to have. Okay, so before we talk about your medical journey, etc., where were you born? Who were you as a little girl?
Yeah. So I grew up in Riverside. So I was born in San Bernardino. And then I grew up in Riverside. Grew up there my whole life. Went to UC Riverside for college. And I'm still in the area.
How were you as a student?
So as a student, I wasn't like the smartest kid in school, but I was very persistent. So I don't think you have to be the smartest. You just have to be have that perseverance.
Yeah. Okay. How were your parents? What was your home life like?
So my parents were super, super hard workers, still to this day. I grew up in a very traditional Mexican household. My parents worked. We never saw my parents.
Really?
Yeah, when we were growing up. So they just worked so much.
Who took care of you?
So my older siblings.
Really?
Yeah, so I'm the youngest of 4. And my older siblings always watched us. We kind of all made dinner together. But my parents, they worked so much. And I feel like it was that very old Mexican kind of mentality.
Yeah. So you're a persistent student. Did you know then that you wanted to be a doctor?
No. So I never even knew that I could be one. I never.
Did you have any doctors in your family?
No. So in Mexico, but it wasn't really a thing in my head. I didn't know that I could be a doctor. And I didn't really know anyone here in the U.S. who were doctors, especially not Latinas. And so really, it wasn't until high school where I saw it on TV on Grey's Anatomy.
No.
Yes. Grey's Anatomy. I started watching Grey's Anatomy. I thought it was so cool. And I was like, that would be so cool to do. So I just kept working hard in school. I started volunteering at the local hospital, which actually is where I'm a doctor now.
No.
Yes. Yeah. I'm a doctor at the hospital that I volunteered at in high school.
Oh my gosh.
Yeah.
Okay, so high school, you're like, a doctor sounds fun. So where you go to college, UC Riverside, and then medical school. Tell me about that.
Yeah. So
If you were a persistent student and it wasn't easy for you, medical school is not easy, period, to get into or get through. How did you do that part?
So that also was a lot of praying, a lot of rosaries, but still a lot of persistence as well. But so in college, I was a religious studies major.
What?
Yes. So a lot of people don't know you don't have to be a science major to go to medical school. You just have to take all of the required sciences, all of the prerequisites to be able to.
That any student has to take.
Right. Well, no, the prerequisites to apply to medical school.
Like biology.
Yeah,
Okay.
all of the sciences. So you can be any major as long as you take all of the medical school prerequisites, you could still apply to medical school.
How interesting.
And I would say that if you're a non-science major, it kind of admissions committees kind of pick you out of the crowd because they're seeing a sea of chemistry, biology, and then all of a sudden religious studies.
Ooh.
Yeah. And so then I feel like it really helped me to understand different cultures better because I studied every religion.
So good.
Yeah.
Yeah, that makes total sense. And you have more of a sensitivity to the differences and whatnot. So where'd you go to med school?
So I went to California University of Science and Medicine. It's in the Inland Empire. So it's a newer MD school that one of the local county hospitals kind of brought about. Yeah.
And I think that's probably in response to the lower enrollment that's happening nationwide
Yes.
with doctors in general.
Yeah, the physician shortage, especially in California, it's growing. Yeah, the shortage is growing.
Okay, so you go through medical school, and then tell me, for people who aren't familiar with the medical school process and then where you end up, what was that?
So backing up a little, I did my master's in biomedical science.
Oh my God.
California is one of the hardest states to get into medical school because we have all of the most amazing medical schools here.
Yeah.
UCLA, like USC, all of them, right? Mm-hmm. So, and everyone wants to come here. So you're getting the best of the best applicants trying to come to California.
Right.
So I knew that I needed to stay in California because I'm like total family girl. Mm-hmm. I would not survive if I went to another state.
Sure.
So there are master's programs that have kind of like a gateway into their MD program. Oh. So I said, I'm going to do that. I'm going to do a master's in biomedical science. That way, medical schools take me more seriously too, having a religious studies bachelor's. If I have a master's in biomedical science, maybe they'll take me more seriously.
So, I mean, talk about the road less traveled. Religious to medical.
Yeah.
Like, I just want to focus on that. That's so good. It's so not cookie cutter.
Yeah, it's not. It's not at all.
I love that though.
But I wouldn't change a thing. Sure. It was definitely a little more challenging. But I wouldn't change it because I think at the end of the day, I stuck out among many different applicants. Yeah. And so I did my master's of biomedical science at this medical school where I ended up getting into medical school. I did my master's there, and I treated my 1-year master's program like a 1-year-long interview. And I am queen of networking. So I said, I'm going to make sure everyone at that medical school knows my name, knows who I am, has something positive to say about me. That way, when admissions committees are reviewing my application and my name comes up, it's like absolutely, we have no hesitation that she should be in our MD program.
So smart.
So I only applied to one medical school, and I got into that one medical school, and that's it. So, which is like rare, right? People have to go through multiple seasons of applications. You apply to basically everywhere in the entire country. You apply to both MD and DO, but because of the way that I did it, I knew if you got a certain score on your MCAT, you were guaranteed an interview. Mm-hmm. So I had that certain score. I had a guaranteed interview to that program. They gave me an acceptance, and that's the only school that I applied to.
So your plan worked out. A very risky plan, and it worked out.
Yeah.
Okay, so then you get through medical school.
Yeah.
And then what happens then?
So I get through medical school, and then while you're in medical school, you're trying to figure out what specialty you want to be. And for the longest time, I thought I wanted to be a cancer doctor. Until I realized when I was doing my cancer hematology oncology rotation, it wasn't what I thought it was. I wanted to do more preventative cancer.
Yes.
Until I did my internal medicine rotation. Yes. And I realized that's where the prevention happens. Because by the time you see a hematologist oncologist, it's too late. You already have cancer.
Yes.
Yeah.
Okay, so that's how you figured it out. Mm-hmm. Okay, and then so you decide you want to go into internal medicine. Mm-hmm. And then what's the name of that ceremony you have? The
white coat ceremony?
That one.
Yeah.
That's where you are officially done. Or explain that to me. How does that work?
So when you're in once you get into medical school, you have your white coat ceremony. That's like day one.
Yes.
You get your white coat.
Are you officially a doctor?
Yes. I have my MD.
Okay.
Yes.
So when you're in medical school, you are officially an MD.
No. When you're in medical school, you're a medical student. When you graduate medical school, then you're an MD.
And that's when you get your white coat.
You get it from day one.
Okay, but you're not a doctor yet.
But you're not a doctor.
See, I'm answering questions for you guys because I know we have these questions.
Yeah.
Okay, so then you graduate med school. Now you're officially a doctor.
Yes.
And then how do you find work? What do you do?
So there's a thing that's called match day. So match day is where 4th-year medical students who are graduating, they find out where they get their first doctor job. And leading up to that day, you have interviews from different hospitals, but you have to be granted these interviews, right? You apply to this one localized system. Your application goes out to all these different hospitals, and they grant you an interview or not.
Which doesn't mean you were accepted. It's just an interview.
Just an interview.
Okay.
And then it goes through this really weird process called ranking, where you rank all of your interviews number 1 through however many you had. And it has to match up. Like they have to rank you number 1 and you rank them number 1 for you to be able to go there.
My goodness.
It's not like, it doesn't make any sense.
It doesn't
the match process, but that's how you basically get your first doctor job out of residency.
Okay.
And your first doctor job out of medical school. Your first doctor job out of medical school, you're in training. So you'll be in a program from anywhere from 3 to 7 years.
And that's residency.
Residency. That's where I'm in right now.
Okay. So you're in your residency in internal medicine.
Yes.
You wanted to match with internal medicine.
Correct.
And of course, your plans work out for you.
Yes.
And you matched with internal medicine.
Yes.
Okay. So what year are you now in your residency?
So next month I'll be in my 2nd year.
Okay. So 2nd year of residency. So now you're out there. You are actually treating patients and you are in Riverside, which for people who don't know is what class would you say? Is it lower to middle?
Yeah. Lower, definitely lower to middle.
Okay. So it's a lower to middle class demographic of people. And we all know that people from lower and poverty classes are not healthy. They've usually never been to a doctor. These are people who, they don't go to the doctor when they have a temperature or they have the flu.
They don't.
It's a privilege a lot of us, I don't think, realize that we have.
Yeah.
And so they go to the emergency room when it's very dire and, through the system, they end up seeing the internal medicine doctor.
Yeah.
Or you're not triage, right? That you're not the first line of.
No.
So how do they come to you typically?
Yeah. So what an internal medicine doctor is, it's the doctor, basically we're hospital medicine specialists. So we work in the inpatient side, which is the hospital side, and then we can also work in the primary care setting, which is what in residency we do both. So I see patients in the hospital and on the clinic side. So internal medicine, when a patient comes into the hospital, they're sick enough in the ER that they need to be admitted, then I'm the doctor that handles their care, handles everything. Their pneumonia, their stomach bleed, their whatever it is, right? Their stroke. And then internal medicine will call in the specialist when we need help. When there is a stroke, when there is a heart attack, we'll call the cardiologist, things like that.
Okay. So now that we understand the structure of your work, talk to me from a doctor's point of view. And this is not to be considered medical advice. Disclaimer, lawyer disclaimer. This is not medical or legal advice if we're talking about it. This is just informational. What are top 3 things that you see from the patient demographic you treat that you would recommend our listeners to be mindful of?
Yeah, one of the biggest ones is taking NSAIDs, things like ibuprofen.
NSAIDs.
Yes.
NSAID.
Yes. NSAIDs, like ibuprofen.
I just took 2 today.
That's okay.
Okay.
But there are some people recently had... It's okay. It's okay. No. It's not bad. I'm saying long-term use.
Like, what does that mean, though?
So, for instance, I had a lady who would take whatever, it was like a nighttime, like ibuprofen, and she would use it to help her go to sleep.
Every night, just one?
Every night.
Okay.
Every night.
It's Advil. It's over the counter. Big deal.
But they can cause stomach bleeds, stomach ulcers.
Jesus.
Yeah. So I think that's something that we don't think about, that even over-the-counter medicines can be harmful. So too much of one thing is not good, right?
Right. But Advil does really work.
Yeah, but you shouldn't take it every
I know.
day.
I'm just saying. So instead of Advil, but like, doc, my bones hurt. I don't feel good. I have muscle soreness. I have a cold. Advil, cold and sinus.
Yeah.
Freaking works.
Totally.
Fine. So then for the everyday ache and pain, what would you advise?
Okay, so I think exercise is one thing people really...
See, I always tell you.
Yeah. If you've got those those muscle aches, if you're a sedentary person, you've got to get your body moving.
Yeah.
So I always try to explore non-pharmacologic pain management, right? Like if someone is having, even the people who have knee arthritis, I'll send them a referral to physical therapy. Do some physical therapy.
Really?
Yeah, I do. I refer physical therapy a lot.
Yeah. That is the antidote most of the time. You're right. The movement. Okay, so number 1, NSAIDs. Watch how much Advil you take. Take probably Tylenol or Aleve better.
Yeah, sure.
Fine.
And it's okay when you're sick to take it, but just long-term use is not good.
Okay.
Yeah.
Number 1. Number 2, what's another thing listeners, people watching this should think about for their health?
Cancer screenings. Yeah.
Everyone's so scared to do that, though.
I know. know, it's scary, but think about how much more scary it is for you to have a cancer that goes undiagnosed and then you're to the point where, God forbid,
It's too late.
It's too late. So the USPSTF, this is the United States Preventative Service Task Force, they just released new guidelines for breast cancer screening. It is now age 40 that you get a breast cancer screening.
Mammogram.
Sorry, mammogram, yes.
But that's the same thing,
yes.
right?
Yeah.
Okay, so age 40, women should, and I think a lot is, what's happening is sometimes some primary care doctors are not recommending them.
Yeah.
And so the patient does have to become their own advocate. And so that's why information like this is so super important.
Yeah.
Patients should feel comfortable with this information to tell the doctor.
Yeah.
And it's okay to ask the doctor questions.
Yes.
I'm sure you get a lot of people who are intimidated too.
Yeah.
Right?
Yeah. Yeah, absolutely. I think trying to empower them and trying to help them be responsible for their own care, because there is a lot of doctors out there who maybe are not up to date with the latest guidelines or the latest medications. Right. There are some physicians who are great physicians, but they've been practicing so long that they're not comfortable with the medications that are out now.
Sure.
Medications that I'm training with, but they weren't even around when they were training. You know?
Right. And then what would you say is the third thing for listeners, maybe our age demographic?
Yeah.
Our age, early 30s.
Yeah.
To 40, 50s, just because now is the time. We're building the foundation for 70s, 80s, 90s.
Yes.
What should we be thinking about?
Controlling your blood sugar.
What does that mean?
So diabetes is rampant. So diabetes is one of the leading causes of blindness here in the U.S., leading cause of chronic kidney disease. So renal failure. So when people have to go on dialysis, needing amputations. And then when their blood sugar is so uncontrolled, I see this a lot in the hospital, people will have these diabetic foot wounds. Once you have such bad diabetes, you start to lose feeling in your legs and in your feet. So people, if they're not wearing shoes, they can step on something. It becomes a wound because their body doesn't have good wound healing. So then it becomes this wound, can get infected. They go septic, these downstream effects. So when I see people in the clinic, and if they have diabetes, I try to stress to them how important it is that they keep their diabetes under control. Because even though we have diabetes medication and everyone has diabetes, it's not something to take lightly.
Right. It's very dangerous.
Very dangerous.
And I think if you're genetically predisposed to it as well, you have even more reason to be vigilant and alarmed maybe and take action now. And I think when we talked the other day, just because you're predisposed genetically it's not an automatic sentence.
It's not.
What can people do? Can you avoid, well, everyone in my family has heart disease, so I'm going to have it, or diabetes or whatever. I know some stuff genetically probably you can't, but
yeah. So there's this meme that I love, and it's this patient telling the doctor, no, doctor, you don't understand, diabetes runs in my family. And the doctor said, no, the problem is no one runs in your family.
No one runs. No one runs.
Yes. So exercise, controlling your diet. And I think really, it's no one's fault, but I think people don't really know how to eat healthy, especially in my patient population. My patient population, we really educate them. We refer them to diabetes education, nutrition services so that they can have a nutrition consultation with a nutritionist.
What is their average diet right now, generally speaking?
Like flour tortillas.
Every day?
I'm sure, yeah. And rice, and because it's predominantly a Hispanic area.
Okay.
So low socioeconomic status. I see a lot of farm workers. I see a lot of immigrants. I see a lot of prisoners. So a lot of people who don't really have access or the means to afford really healthy food.
Yeah.
So things like, it's really cheap to get a 99-cent burrito at Del Taco or something like that, right?
Mm-hmm. Okay. So I want to switch gears now because you mentioned prison population. And this is so intriguing to me. So your name is Doctor.Celebrate.
Yes.
And we can follow you. I'm going to put her information right here in the comments. Please follow her. first question, why the name Doctor.Celebrate?
Yes. So I feel like I'm someone who I feel like life is meant to be celebrated. We go our whole lives and we're waiting for that one occasion, but every day is that occasion. Yes. Like celebrate every day. Don't wait for that one thing to wear that one outfit. Like you are the moment.
Wear it.
Wear it. And so I think, especially in COVID, I think this was highlighted. We had different priorities and just really having a well-lived, happy, joyful life. Mm-hmm. Not saying that bad things don't happen, but, when you have a more positive outlook and you celebrate the little things, like I really had to romanticize my life during COVID. I was like, oh my gosh, every cup of tea was like the best cup of tea I've ever had. Yeah.
Isn't that funny? We can like really though, if you think about it, like I'm alive.
Yeah.
We're just sitting here talking. We're healthy.
This is the best.
We're just snatched and we're talking. And we're just talking.
Yes.
Like, wow, how lucky are we?
Yes. And
that's something.
I'm the biggest believer in fake it till you make it, because the more you fake it, like you actually believe it. Like
we become what we believe, we become what we think. I know, I say it all the time. Okay, so talk to me about this prison population.
Yeah, so that's also why I don't really have my real name on the internet. So in my county hospital, we have a jail in the county hospital, and there's no separate jail doctors for the hospitalized prison patients. Whoa. It's us. It's internal medicine.
My gosh.
Yeah. So I think for safety reasons, I don't necessarily want any of my patients, not just the prison ones, but any of my patients to Google me and, be able to.
Yeah. Everything's so available online now.
Yeah.
Okay. Well, that's smart. See, something to think about. And that is so different than how everyone thinks right now. We put everything out there.
I know. And I'm more of a private person, but I thought long and hard about even doing this Doctor.Celebrate page. But one of the reasons I did it was because when I was in college and when I was in my master's program, I would see other med students or residents on social media, and I would think, oh my God, okay, if they could do it, I could do it too.
Really?
Yeah. So one of them, Dr. Leslie Gonzalez, she is a family medicine resident. Okay. I watched her whole journey on Instagram, and like every time I was like, oh, I don't want to do this anymore. Like there would be certain people, Leslie was one of them, because she would lay out her whole journey, her whole medical journey, and I'm like, okay, I could do it. Like I could do this. So part of doing my Doctor.Celebrate is like giving back and showing my journey. And I do get these young women who will repost my video and be like, I can't wait for that to be me one day. And I'm like, okay, this is why I'm doing
working.
Yeah.
Yeah. Representation matters.
Yes, it does.
Yes. I understand it and I know it. And so we connected over Instagram.
Yeah, we did.
Because I'm like, first of all, who is she? And she's so pretty. And then I'm like, Doctor.Celebrate. Sometimes people use the word doctor and they're not.
NMD or DO. Yeah.
I don't make the rules, right? The rule says if you are an MD, you are a doctor. If you don't have an MD, you're not a doctor. PhDs call themselves doctors, but...
And dentists. I'm just kidding. No shame. No shame.
Listen.
They have doctorates.
And again, my dad was an orthopedic surgeon, and so I'm kind of partial.
Love our dentists.
Oh, love them. Yes.
Love our PhDs. We need all of them.
We need everyone.
We need everyone.
Okay, fine. So I forgot the point I was trying to make. I started going in.
Or Latinos in healthcare.
Yes, Latinos in healthcare. What is the percentage? Is it like less than 2% in our country?
So 2.4% Latinas who are physicians in the U.S. Wow. Less than 7% Latinos as a whole who are physicians in the U.S.
Ay.
So there's this huge movement. It's the National Latino Physician Day, which Dr. Michael Galvez and then Dr. Cesar Padilla, he's a Stanford anesthesiologist, OB-GYN anesthesiologist.
Cool.
So they co-founded the National Latino Physician Day to kind of celebrate us and bring light that, less than 7% is not enough.
When is the day?
October 1st.
Okay. Mark the date. Yes, we're going to have a party.
October 1st.
It's so important. And it's important but scary because as we know, the population in the United States will soon be majority Latino.
Yes.
And a majority of that Spanish speaking, I would think. And if we don't have physicians or specialists who actually speak the language, you know better than anyone, there is a steep drop off in positive outcomes with patients. Yes. Just think about it. Like if you're trying to communicate with someone and you're not feeling good and you're hurt and you're in a different country, you're on vacation, let's just say, you're in this country where you don't speak the language and you're hurt and you need medical attention.
It's scary.
Try communicating to that person.
Yeah.
What?
Yeah.
And that is happening here in our cities where we live.
Yeah.
So, anyone out there that is thinking about going in medicine, and especially if you speak Spanish, I don't care if you're Latino or Latina. Yeah. If you speak Spanish, we need you immediately.
We do.
So, okay. What would be some takeaways that you would want people listening, patients, etc., to bear in mind? Okay, summer's coming, and I know people are just like, oh, it's summertime to party. I know that healthcare, like people go into the hospital a lot more during the summer.
Yeah.
People don't know how to take care of themselves.
Yes.
Tell me about
4th of July, firecrackers, all those things.
Right. Which I thought was like silly. I thought it was a joke, but no, people really get killed or
they do
lose limbs.
Absolutely.
Have you treated any?
Yeah. I have not because I'm not an ER doctor, but
that's right.
It comes in the time, comes into the hospital all the time.
Oh my gosh.
Yeah. Especially 4th of July.
In general, for women, since mostly women are going to watch this, what are some top 3 screenings they should always consider, no matter where they are in the stages of life?
Yeah. So breast cancer screening, colonoscopy for colon cancer.
I just had one.
Yay!
I just had one like 3 weeks ago.
Yeah.
It wasn't that bad at all. Well, first of all, the hardest part was drinking the
Go lightly, the prep, the bowel prep.
The bowel prep.
Yeah.
That is the worst part of it. And all it is like you just have to be near the toilet the whole day before. It's true. So what? Yeah. And the colonoscopy part, you're asleep. You don't feel anything. Thank God.
Yeah.
Okay, so breast cancer screening, colonoscopy screening. Around what age? Colonoscopy. Talk about the rising rates of colon cancer in young people. I've been seeing so many articles, and it's why I advocated for myself.
Yeah.
The doctor told me, oh, well, you're actually not the demographic yet.
Yeah.
You have to wait 4 more years. I'm like, I want it now.
Yeah.
I want it.
Yeah. So about 45, is usually when, we should start screening, unless you have something else concerning or you have a family history or, your own personal history.
Right.
So, yeah.
Okay. And then so breast cancer, colonoscopy screening, and what else?
Yeah, I would say, I think for the younger generation, because they're the ones who are not really coming in to do like preventative health maintenance appointments, and they really should. When you're young, you don't think anything's going to be wrong with you, but STD screenings.
Oh, that's huge.
Huge. I think we need to create a more open dialogue about the things that feel embarrassing to talk with your doctor about, like things surrounding sex and STDs and things like that. Especially, I'm training to be an HIV specialist as well. We talked about this before. So I'm in a combined internal medicine HIV specialty pathway.
God.
And the medications that we have, like we can put you on a medication before you engage in any risky behavior to prevent you from getting an STD.
Really?
Yes.
What?
Yeah.
Why doesn't anyone talk about that?
That's what I'm saying.
Wait a minute. Back up.
Yeah.
Repeat that again.
There is a medication that we can put you on. It's prophylactic. So you can take it surrounding when you're doing any risky sexual behavior. So we have that for HIV. It's called pre-exposure prophylaxis. We also have post-exposure prophylaxis to kind of prevent you from getting HIV surrounding any risky sexual behavior with someone who you might think or has HIV. Same thing with gonorrhea, chlamydia, syphilis. We can give you a medication before, or if you've had exposure after, we give you an antibiotic and it'll prevent you from getting it.
Like 100%?
I mean, nothing's 100%,
but like
medicine.
They wouldn't be giving it if it didn't work.
Yeah.
This is part of the conversation you're talking about people being embarrassed to talk about this stuff with their doctors.
It's not embarrassing. Like everyone has sex. Like it's a human thing.
It's a human thing.
It's like breathing air, drinking water. And I think it's embarrassing to talk about it with your doctor, but who else are you going to talk about it with? We're the ones who can help you.
Okay. So everyone book their doctor appointment right now for your annual health screening. Just go in, get your blood pressure done. I know it's scary. I know it's intimidating. You're scared of what they might find. But like the doctor said, it is scarier when it presents down the road. If it's probably nothing anyway, but if it is something, then you should be really scared when it presents and it's a runaway train and now you're really effed.
Let's catch things early. Because especially high blood pressure is the number one risk factor for stroke too.
Okay. So let's, and this
control your blood pressure.
This is part of an annual exam.
Yeah.
Go get it. Okay. So I have a question about this Ozempic craze.
Yes.
Everybody I know has Ozempic. Is it getting Ozempic?
Yeah.
And it seems to be working. Like people that I know who have had weight issues, you can see the transformation. Mm-hmm. What are some warnings people should be mindful of?
Yes. So I love Ozempic. I prescribe it a lot in our county clinic. But I think it's important to differentiate Ozempic versus Wegovy. So Ozempic is used, FDA approved for people with type 2 diabetes, right? And then Wegovy, it's the same medication, but it's a different brand name. But that one's FDA approved specifically for weight loss. So we'll use that for people when they want to lose weight, but they don't have diabetes. And then most of my patients in the county clinic who have diabetes, they're on Ozempic. And it's great for controlling their hemoglobin A1C, which is the average of your blood sugars over 3 months, right? We want it to be less than 7. Usually my patients in the county setting, their A1C is like 9, 10 high, right?
Okay.
The problem that I see, it's so super trendy. The problem is some med spas are getting Ozempic through a compounding pharmacy. We don't know what's in that compound. I know people who have come to me with joint pain after taking Ozempic or after starting Ozempic. And I'm like, that's not one of the side effects. Usually nausea, vomiting are one of the side effects, but not joint pain. And then I know other people who have felt just weird on compounded versions of Ozempic that they're getting from med spas.
Oh.
Yeah. So
be mindful of that. And so what should they ask? What questions should they ask at these med spas?
So I don't think you should get Ozempic from a med spa.
Oh.
Don't get one from a med spa because I think med spas, I don't know. Some of them, I don't know how regulated they are.
Right.
And, there's not always a physician present. I think you should be getting your Ozempic from a doctor.
Okay.
Who...
Like an actual doctor should be administering.
Yes. A doctor should do a physical exam on you, should know your past medical history, should know basically your medical history and see if you're a candidate for it. Because there's people getting Ozempic from these med spas to lose 5-10 pounds. It's not for that.
No. Okay. Yeah. All right. So again, be your own patient advocate. Yes. Don't follow the trends.
Right.
Be careful. You're ingesting and putting stuff in your body that could have some pretty bad side effects.
Yes. And I know it's trendy right now and everyone wants to lose weight, but there's better ways to go about it. Right. Eating healthier, exercising, that's not just going to help you drop pounds, but, cardiovascularly, it's going to help you. But I love Ozempic. There's new studies coming out, things that we call like fatty liver disease. And then when you have visceral fat, which is fat around your organs, like fat around your heart, Ozempic is helping with that.
Really?
Yes.
So that's very good.
Really good.
Preventative.
So, yes.
I love that.
Very
Okay.
preventative.
Okay. Well, now you know. Okay. So my friend, I appreciate you spending your time here. I'm going to have you back because I know you're just like a wealth of knowledge, and healthcare, especially for women, is such a big deal. And I really want to continue the conversation and make sure we continue to advocate for and empower women and people to be advocates for the health. So I appreciate you, friend. And then I'm going to put how you can follow the doc. I will put it in the caption. And please follow her page and watch her be the incredible Doctor Celebrate that she is.
Thank you.